Hi, everyone, and welcome to DIS Combat Congenital Syphilis. My name is Leandra Lacey, and I serve as the Senior Manager of Capacity Building and Member Engagement for the National Coalition of STD Directors, or NCSD. Thanks to all of you who have joined us today, especially given the rapidly changing landscape of COVID-19 response right now. So let's get started. The number of congenital syphilis cases around the country has dramatically increased by 185% since 2014. This increase is a symptom of the nation's STD crisis. DIS are key players in engaging their communities and following up on potential congenital syphilis cases. But how is this being done across the nation? Today, you'll hear lessons learned and best practices on engaging with pregnant women and addressing congenital syphilis in two different jurisdictions, Arkansas and Massachusetts. All participants have been muted. If you have questions or need technical help during this call, please use the chat box on the right side of your screen. You can also private message me or my colleague Tiffany Haskell or Jenny Mann, who are both listed as a host. All questions for presenters will be addressed at the end, but we will keep a queue, so please send them our way as they come up. This webinar is being recorded. The recording and presentation slides will be emailed to those that are registered. These materials will also be placed on the NCSD website. So for today's webinar, we're looking to highlight DIS messaging to encourage prenatal care and syphilis testing, local partnerships for engaging with pregnant women and addressing congenital syphilis, and then lessons learned and best practices around congenital syphilis follow-up and DIS engagement with pregnant women. So I'm really excited for this information that will be shared today, and I hope that you find it timely and relevant. So for today's agenda, you'll first hear from Brandi Roberts from the Arkansas Department of Health. She'll then be followed by Lorena Gjino, Massachusetts Department of Public Health. And then we'll also have a Q&A where you'll be able to submit your questions via the chat box. So feel free to put those questions in the chat box as they come up for our speakers, and we'll be sure to address at the end. So first up, we have Brandi Roberts from the Arkansas Department of Health, as I mentioned before. She is coming to us from Little Rock, Arkansas, and she serves as the STD Prevention Program Manager there. Brandi, take it away.
All right. Thank you, Leandria, and hello, everyone. I am glad to be here in midst of COVID, that I'm actually able to spend an hour of my time actually working on STD stuff versus COVID. So I'm definitely glad to be here, and thank you, NCSD, so much for letting me talk about what we are doing here in Arkansas as far as congenital syphilis and what our DIS are doing to kind of combat congenital syphilis here in Arkansas. So as Leandria mentioned, my name is Brandi Roberts, and I serve as the STD Prevention Program Manager for the Arkansas Department of Health. So I want to go ahead and give my first disclaimer to say is that, I'm speaking on behalf of the program, but we do have, our DIS who I have to give the credit for this, because they are the ones who make this possible for us to be able to do this follow-up for congenital syphilis across the state. So definitely want to give kudos and shout-outs to my DIS in Arkansas, because they are the ones who are actually the boots on the ground to make this work for us here in the state. So it's not just me. It's my wonderful staff in Arkansas as well. So thank you guys so much. So to start off my presentation, so how we are using congenital syphilis to combat congenital syphilis in Arkansas. So my objective today is to kind of go over a quick overview of congenital syphilis in Arkansas, to talk about the GYNS role in congenital syphilis follow-up in the process, and to go over some quick successes and next steps for congenital syphilis follow-up and kind of what we do here in Arkansas. So just to kind of give you a quick snapshot of Arkansas. So Arkansas, we are definitely right above Louisiana. We are a very, very rural state. So outside of a few highly populated areas like the capital city here in Little Rock, Fayetteville, home of our Razorbacks, and some other sprinkle of areas across the state, we are pretty much rural. So a lot of those areas have a low population density, and we have your typical where you have houses that are almost a mile away from each other, and of course you have your typical, transportation issues, access to care issues and things of that sort. One thing that I do want to let you guys know is that we actually expanded Medicaid in 2013, and just kind of as a caveat, as I begin to kind of talk about, congenital syphilis, that, Arkansas is a Medicaid expanded state. So in 2018, 20% of our infants were born to women that have inadequate prenatal care, and as you guys know, with congenital syphilis, that is definitely a very important factor, when it comes to, congenital syphilis follow-up and, what, we kind of have to combat as we're actually working congenital syphilis cases and women with syphilis. And then just so you know, Arkansas, we were ranked number 6 in the state for congenital syphilis cases in 2018. So just to kind of throw it out there, so even though Arkansas was pretty small, we have about 3 million people here in the state. We are considered as a medium morbidity state. So we have roughly around 17,000 cases of chlamydia, about 73,000 cases of gonorrhea, close to 300 cases of primary and secondary syphilis. And then in 18, we had about 25 cases of congenital syphilis, just to kind of give you a sense of our morbidity across the state. So we're kind of small, but we still got some numbers here now. So just to kind of quickly look at how our syphilis is across the state. So as I mentioned, and as you can probably see from this slide, with the areas of dark red, those are our highly populated areas, which tends to have, the majority or bulk of our syphilis cases. So if you look smack dead in the middle, that's Little Rock, Pulaski County, and then we have Miller County, which kind of borders the Texas group over there. So, hey, Texas, y'all contribute to a lot of syphilis and congenital syphilis over there on that corner, over there in Miller County, and then just some sprinkle of other areas, that tend to have, congenital syphilis and syphilis in those areas. And most of the areas, as you see, they're grayed out because they're suppressed. That just pretty much means that, as I stated, we're roughly rural, so we don't have that many cases in those areas. So we suppress those cases. But you kind of get the gist of where most of our people are in Little Rock, just kind of looking at where the dark red places are. All right. So even though we're smart, we're a small state, you see we have a huge impact, on our congenital syphilis in the state. So as you can see, what I have circled in red is that we are up there with Texas, Louisiana, Florida, in which we have a significant rate of congenital syphilis in our state. So as I mentioned, we did rank number 6 in our congenital syphilis across the state. So we definitely had to do something about, our process and our efforts, for congenital syphilis in our state. All right, guys. So I know this graph is going to shock you because it shocked us as well. Okay. I see my sound is breaking up. Can y'all hear me okay?
Hey, Brandi, it's a little bit choppy. I'm not sure if it's your cell service or not. Try to talk again.
Okay, can you hear me now?
I can, just a little breaking up.
Okay, so they said that both people are choppy. Can you hear me now?
Oh, my audio is also apparently breaking up. It may be the Adobe Connect connection.
Okay.
We may just have to push forward. Sorry about that, you all, because I don't want to kick everybody off the line and have everybody come back, so we will try our best.
Okay. Can you hear me now?
Yeah, it's a little bit choppy, but I can hear. Yeah.
Okay. Okay. All right. Did you want me to keep going or?
Let's see. I wonder if it's just our phones. Brandi, let's try. You dialed in when you got onto Adobe, or did you dial out?
It called me.
It called you? Okay.
Yes.
Let's see.
Okay, so Amanda can hear you, Leandra. Amanda, can you hear me as well? Can y'all hear us okay?
Yeah, I think, Brandi, you're still choppy a little bit.
Okay.
But they say they can hear me pretty fine, but it seems like you might be a little bit choppy. What I would suggest doing is, let's see, I don't want you to hang up.
Okay, because I can try to call from my office phone if that will work.
Yeah, try that. Do you have the
Let me
direct line? Do you want me to give it to you real quick?
I was going to disconnect and have it call me.
Okay, perfect. Hi, everyone. We'll wait a second for Brandi to dial back in, and then we'll continue with the webinar. Thanks for your patience. Brandi?
Hey, Leandra, can you hear me?
Do you have us on hold by chance on your other line?
Let me see.
Hey, I can hear you now. Oops. One moment, everybody, as we work out the audio issues. Thanks for your patience. We'll wait for Brandi to join again. Thanks again, everyone, for your patience. We're just trying to work out the tech issues, and we'll get started right in a second. Hi, Brandi. It's Leandra. Can you hear me now?
Yes, I can. Can you hear me?
I sure can.
Okay, does it sound okay now?
It sounds a lot better.
Okay, great. Sorry about that.
That's all right, and thanks everyone for your patience. We'll jump right back into Brandi's bit. Thanks so much.
All right, thank you. Thank you, everyone. Sorry. So to go ahead and keep along with the presentation, see, we're innovative, we're DIS, we're used to having hiccups. All right, so as I was mentioning, so on this graph that you see now is our reported cases from 2015 to 2018. So I know you're shocked, right? We were shocked as well when we seen how significantly that our congenital syphilis cases jumped up for our state. So from 2015 to 2018, we had a 418% increase of congenital syphilis. So everyone who works on the PEACH grant, you now know that we had to start a congenital syphilis review board, and then also we had to kind of change our processes on how we actually manage our congenital syphilis cases across the state, because now since we were seeing an increase in syphilis, we were now beginning to see an increase in our congenital syphilis cases as well. And this just kind of shows the rate. So as on here, on this graph, you can pretty much see the rate and also see the big jump as well of how we increased significantly from 15 to 18 with our congenital syphilis, and then also how we are compared against the United States as far as our rate of congenital syphilis. So we definitely have a problem in Arkansas as far as congenital syphilis cases. So just to kind of talk about the STD program and here in Arkansas in our program structure, so our DIS, kind of like other programs, they are housed under our STD prevention program, and we are an integrated program with HIV and STD. So our GYNS, they do partner services for both STD and HIV cases. Our program consists of our STD field operations manager, who manages our 5 regional DIS supervisors, and we have 20 DIS that are located across the state of Arkansas, who pretty much does, like I mentioned, partner services for both STD and HIV cases. We do treatment verification for our gonorrhea and chlamydia cases as well. So what were some of the challenges? So as I mentioned, because we did a slight jump, with our congenital syphilis cases, we had to kind of change how we did things. So we were having a couple of challenges as far as our congenital syphilis process. So one of the first things that, I have on here I want to mention is that we had competing program priorities as far as, follow-up on our congenital syphilis cases. So at first, we have what we called CDNS, or communicable disease nurse specialists, who were actually the ones who did the follow-up on our congenital syphilis cases. So one of the things that we were running into is that those individuals or those nurses are actually housed under local public health, which is a different center, which is kind of the same center as our local health department. So one of the things is that the STD program actually does not foresee or have any type of supervision over those nurses. So even though they did the kind of follow-up on our congenital syphilis cases, because we didn't supervise them or kind of oversee some of their efforts, it kind of led to some different priorities when it came to, different programs. So oftentimes, because they were tasked with working flu, hepatitis, they supervised our nurses, they worked counties, they seen multiple patients. Oftentimes, our congenital efforts would kind of fall on the back burner, and we would end up, having some issues such as like delayed reporting with them getting the information to us, with follow-up being done on some of our congenital syphilis cases. So, and then with us having so many, being on top of like the things that they were already doing, it started to kind of become a problem, because now they had a lot more work that they had to do with our congenital syphilis. Duplication duplication of effort. So because we had, our DIS, working some of our, interviews with our mothers and then also trying to coordinate with the nurses, sometimes we tend to have, duplication of efforts as far as, different individuals calling to follow up on baby, different individuals calling to follow up on mom. So we pretty much had to kind of streamline that process as far as follow-up because, just to make sure that, we didn't have different individuals that were kind of calling, getting the same information, and that we had one person to actually do that. And then also one thing that I also wanted to mention is a training on our surveillance system. So here in Arkansas, we use PRISM as our surveillance system. So because our nurses or CDNSs who worked our congenital syphilis cases, they were not in PRISM. So pretty much they would have to send the information up to us and then give it to the DIS or to the surveillance individuals, and they would have to input that information into PRISM. So that was kind of causing some backlog and some duplication of efforts and kind of time-consuming because instead of that information going directly into PRISM, they actually sent that information up. They actually sent that information up here to our surveillance department, and that information had to get put in. So as you can see, that may have kind of caused some issues with, information going into the system and follow-up because oftentimes it was after the fact, and the information would go in after, and that information would actually go in after, the information was put into our surveillance system.
Hey, Brandi, it sounds like you're beginning to be a little bit choppy again.
Choppy again? Okay.
On the phone? Yeah, it may just be the connection. Your phone possibly? Are you on a landline or a cell phone?
I'm on a landline. Can you hear me now?
Still a little choppy.
Okay.
I think this is just the best we can do for now. Sorry, you all.
Okay. Yeah,
Brandi, if you can.
Now to me. Okay.
Brandi, if you can, just try to slow down.
Yeah, because I guess because it's being so choppy. Okay. All right. Okay. All right. And then the next thing that I want to add on here as a challenge as well is pretty much like most other states, we have a hiring freeze. So what we wanted to do as we started to get the increased congenital cases across the state, we were hoping that we can get some additional positions and nurses that will kind of help us with the congenital syphilis workload that we had now. So we were hoping to get some more positions, but because we're a state agency and we were at a hiring freeze at that time, we were not able to add on additional staff. So we pretty much had to kind of, come together, think about, how we wanted to actually get this accomplished and work on, how we can actually better improve our congenital syphilis process with getting that information in because that was a problem at the time. So what was our solution? So what we did is we actually, with the help of my STD field operations manager, so we kind of looked at several processes within our program and kind of looked at how we can kind of make things more efficient with the DIS that we already had. So we kind of looked at their caseload. We changed our prioritization. We changed kind of how we did things to kind of see how we can use what we got to pretty much see can we come up with a better way to change our congenital syphilis process. So what we did after making all those changes, we realized that we had, some free DIS. Well, I don't want to say free, but, because we were able to kind of shift some of those cases to other DIS within the region, we were able to actually pull one of our DIS that we had currently and actually repurpose their position into a congenital syphilis GYNS. So this person pretty much was already a GYNS. She had a clinical background, so it was kind of easy for us to kind of put her in that role as our congenital syphilis DIS because as a DIS, she was already familiar with the process. She was familiar with PRISM already, so she can help with the data entry and things of that sort, and already had a good working relationship with some of our providers in the state so that she would be able to eventually move into that role. So let me show you kind of what that looked like. So how we kind of transitioned her from a DIS to and what we call it a congenital syphilis DIS. So it was the easiest for us to do because we did not have to hire another physician. She was already doing that. We kind of kept it at the same grade. We kind of just repurposed the job description to do only follow-up on our pregnant syphilis cases in the state. So regular DIS, as I mentioned, they do HIV and STD partner services, referral and links to care. And with congenital syphilis, our DIS, they assist surveillance with obtaining the pregnancy status. You know, they still interview the pregnant mom and partners. They do the surveillance staging. They initiate the maternal records in PRISM, and they do our referrals to prenatal care if needed. And so now with our new congenital syphilis DIS, what she does is pretty much she took the task that we had from the nurses in the beginning, and now she is solely responsible for all of that. So what she does is she completes the congenital syphilis reporting form. She follows up on all of our pregnant women with previous and current syphilis infections. So pretty much once our DIS find out that we have a woman that's pregnant, that's syphilis, it actually gets tasked to her in PRISM. And then she helps with pregnancy status ascertainment. She's our primary contact person for our medical providers. So as I mentioned, because we have multiple people calling different providers, that was always the issue for some of our providers. So now she is the primary contact person. So now she is the only person that actually contacts those providers for like your delivery records, your information on mom, and information on baby. And then because she was a DIS, she actually has a good working relationship with our DIS already. So if there's some additional information that she may need from our DIS when they interview the mom, she's able to get that information fairly quickly and efficiently because we're all under the STD program and we all work together. So what is our follow-up process as far as our congenital syphilis DIS? So this is a quick algorithm or process that we created for our purposes for the program, and it pretty much kind of shows you the flow of how we actually do our follow-up with our congenital syphilis. So starting with a pregnant mother, I know that sounds redundant, I need to change that, but a pregnant woman, so of course, you know, the initial case comes from surveillance. You know, we get that positive test. It then moves through PRISM where it goes to the DIS supervisor. They task it to the DIS. The DIS, they find out that that case is pregnant, and then that information gets tasked to our congenital syphilis DIS, and then also the nurses in the regions actually work with the DIS as well because, of course, they still have to do like the clinical aspect with the mom, so it gets tasked to them as well. So we just kind of have the DIS to notify the nurse, and then also the congenital syphilis DIS. So at that time, she actually starts to get the information needed for the congenital syphilis reporting form. So, you know, your para, your greta, the different information that you need from the congenital syphilis form, and she starts collecting that information. And she does that for pretty much all of our congenital syphilis cases or pregnant syphilis moms across the state. And then, of course, you know, once she's finished with that information and she gets done with that, it moves back to the DIS supervisor, and then that information gets closed out in PRISM by our DIS supervisors. So the DIS and the congenital syphilis coordinator, they actually work together because the DIS, of course, they still have to interview the mom, and then also they're working with the congenital syphilis DIS coordinator, or DIS to actually make sure all of that information is complete on the actual reporting form. So for the child, this is pretty much the same process. So if we get a positive baby that comes in, that case is linked to the mom. So if the mom is in PRISM and we have the mom, that baby is linked to the mom. If the mother is unknown, or sometimes we have it where
Brandi, I think you might have gotten disconnected. Can you hear us? You just cut off. Uh-oh. One moment, everybody. Thanks for your patience. Sorry, everybody. You should all be connected still on the phone line. I think Brandi may have lost connection. Just give us one moment. She's dialing back in now, everybody. One second. Hey, Brandi, you should be unmuted now. Are you back?
Okay, I'm so sorry. Can you hear me?
Yes, I can. It's a tad choppy, but I can hear you.
Okay, do I sound choppy now?
It sounds good, yeah.
Okay, all right. I'm so sorry, guys. I don't know what's going on with my phone today. All right, so just to kind of start back off on the child, so pretty much as I was mentioning, we follow up on the child as well. So if we get a positive serology from a child and we link that to the mother in PRISM, and if that information is like the mom is not there, we will actually kind of work backwards and get the information from the mom, do the interview on the mom and so forth. So that tends to happen just a little bit because we do, as you know, some mothers just kind of come to the hospital and just deliver with no type of prenatal care, no testing before delivery. So sometimes we do have to kind of work backwards, with our congenital syphilis follow-up, which the DIS, our congenital syphilis DIS works in conjunction with the DIS to actually get that information so we can get those completed information for the actual congenital syphilis form. All right. Okay, so partnerships. So we have a quite a bit of partnerships with different entities here in Arkansas. So we have our hospitals. So one of our main ones that we have a partnership is with our Arkansas Children's Hospital. So that's our only children's hospital in the state. So most of the times they get most of the babies from our mothers who have delivered with congenital. So we have a close partnership with them in which we're able to kind of obtain information fairly quickly, and also they're able to report that information to us fairly quickly. We do have partnerships with our OBGYNs across the state, our maternal and child health program, our federally qualified health centers, pregnancy crisis centers. They're also on board with us as well. And then through our congenital syphilis review board that we had to form on last year, we were able to gain a lot of partners there, which kind of helped us with some of the messaging and follow-up that we are, doing as far as our congenital syphilis efforts across the state. So some of our successes with kind of moving over to this process with, moving to the congenital syphilis DIS, who's the sole person who actually does the follow-up for our congenital syphilis here in the state. So we have streamlined our congenital syphilis workflow. So instead of it kind of being all over the place with, different nurses, working the cases, we now have one dedicated person who does all of the follow-up for our congenital syphilis across the state. It has improved our communication with our providers. So now, since you only have one person contacting them versus 13, they have one sole person to actually send that information to. So she's able to call, get the delivery notes, labor and delivery information, and so forth from those providers. And even if they have someone that just comes in, just delivered, and we don't have any information, they actually get that information to us quickly, or call our congenital syphilis DIS and say, hey, we just got a mom here. Do you have treatment? Do you have her? And if not, they can go ahead and get that information to each other so we can begin follow-up on the mom. And then what it has done, which is the most thing that I am proud of, is it has caused us to more timely report our congenital syphilis cases to CDC. So in past years, that is something that we have struggled with as a state, is actually getting that information in timely to CDC within like the 30 days that we have on our grant. So with us having this process and one person that's actually working that, we're able to get our information in on time, which is always a big, a good thing that you're actually able to meet your grant deliverables as far as timeliness of your congenital syphilis cases. And then also another thing is the improved accuracy of information. So now that we have one person working on this versus 13 people, now all the information is correct. We do have a QA/QC person that after, the congenital syphilis DIS completes all the information, the STD program nurse reviews it. We actually have a third person that actually comes in and actually QA/QC all of our congenital syphilis records to make sure that all of the information is correct of what we have in PRISM and that is getting reported to CDC. And so some next steps as far as congenital syphilis for here across the state. One of the things that we noticed as we kind of started this follow-up is that we found out that a lot of our providers are, don't know a lot about congenital syphilis. Because we have not had that many cases here, a lot of them didn't think we had congenital syphilis or we had a problem with congenital syphilis here in Arkansas, believe it or not. So we are planning to do some congenital syphilis awareness campaigns to kind of give some information to our providers about congenital syphilis. We're planning to do a couple of symposiums, as I mentioned, for provider education, so to talk about, treatment, because that's what we run into a lot, them not getting the recommended treatment, them not, doing the 3 shots that's required, for syphilis and so forth. We are moving towards an electronic reporting form for our congenital syphilis form. So right now we're still paper, unfortunately, and we're hoping to have that electronically coming soon. And then also we continue to improve our congenital syphilis process because nothing's perfect. We still have some hiccups. Even though it's better than it used to be, we still have some hiccups, and we can also always have improved processes as far as our congenital syphilis process. Thank you so much, and sorry about that.
Thanks, Brandi. No worries. We know how technology and everything can be, so it's quite all right. It's not your fault at all. But luckily we're able to push forward. So thanks again, Brandi, for your presentation. Just a reminder that if you have questions for Brandi or for our next speaker, you can put them in the chat box. Questions will be addressed at the end. We'll be keeping a queue of those as they come up. Our second speaker for today, let me move the slide forward. Our second speaker for today is Lorena Gjino from the Massachusetts Department of Public Health. She serves as a field epidemiologist there, which is the Massachusetts way of referring to their DIS. So Lorena, take it away.
Hi, everyone. Thank you for being on the call. As Brandi mentioned, some of us have also been thrown into the COVID-19 team, and myself included, and so it's nice to kind of get a break and work on syphilis again. So yes, my name is Lorena Gjino. I'm a field epidemiologist. It's really a fancier name to say DIS. I work for the Massachusetts Department of Public Health in STD prevention. This presentation will be mainly focused on how we are combating congenital syphilis in Massachusetts, mainly from a field epi perspective. I will tell you a little bit more about what we're doing in Massachusetts in this topic. So next slide. Okay, so our department has 18 field epidemiologists, and we have 4 field operations managers who oversee us. A lot of us are located in Boston, and some of us are located regionally. We also have 1 public health nurse, Lila Coverstone. I will talk more about her role within our department and her role in congenital syphilis in our state a little bit later. And then Dr. Kathy Shu oversees her, and she's our medical director. All right. So as far as congenital syphilis in Massachusetts, we gathered the data from last year, and we had 7 presumptive congenital cases with 3 syphilitic stillbirths. 2 born to infection stage mothers that were in the early latent stages, and the other mom was in the late latent stage. So the main contributing factors were late entry into prenatal care. One of the moms, the reason for the late entry was because she was a late entry into the United States, and the other two moms had comorbidity with substance use disorder. Okay. All right. So before we go into kind of talking a little bit more about how we ensure treatment, I want to talk about some of the systematic changes that we made within our department to ensure adequate follow-up of individuals biologically capable of pregnancy. So in Massachusetts, nationally, we did see a rise in reportable congenital syphilis cases, and so we implemented additional follow-up steps for pregnant individuals. However, current protocols did not cover the broader pool of individuals whose sex assigned at birth was female and are reproductive age that may have had unknown or unreported pregnancy status. And so we created this protocol that was intended to prevent missing unknowns or unreported pregnancies amongst individuals with positive syphilis serology. And this project has helped us to determine the missing cases or pregnant individuals that would have otherwise not have triggered field follow-up if the pregnancy status remained unknown. And so we are identifying these individuals from ages of 14 to 49, and we are receiving positive syphilis serological tests through an ELR, and we have a reactor desk of 2 research assistants who actually follow up with the pregnancy status. And then we determine what need field-initiated cases follow-up, and then the cases that do not need field-initiated follow-up, we have these 2 research assistants call the providers and ask for pregnancy status. If a pregnancy test was not done, then we will ask about whether the patient has been on birth control and ask about the last period. And if the patient has not been tested, we encourage the providers to actually bring the patient back in and have them get tested and get a pregnancy test. So this is also, I want to mention here, a great opportunity to have that kind of first initial contact with the providers. And so it starts at this step. And so another thing for the cases, when we do field follow-up, we put emphasis on documentation of the medication, the dose, the dates of treatment, as well as interviewing and partner elicitation, of course. All right. 1 second. Okay. All right. So how do we ensure adequate syphilis treatment for pregnant women in Massachusetts? So one of the ways that we identify pregnant women, first of all, is through that reactor desk, and then we identify them through investigation of sexual partners or by case report form submission. The main thing is that we really do prioritize cases of pregnant females. They're our highest priority. We take them seriously. And time is of the essence. We make sure that we contact the ordering providers to gather information within 48 hours of assignment. And we gather clinical information, and we're very thorough, and we gather the stage and symptoms of syphilis, their HIV status, number of weeks the patient is pregnant when positive test was collected, treatment and treatment dates. We make sure that we document treatments weekly, and if multiple doses. And then we gather expected date of delivery as well as the hospital that they plan to deliver. And then we try to gather some information about partner, whether it's the father of baby or someone else, and treatment information. So after we get the clinical information from the provider, we then notify our public health nurse of this case. And I will talk more in detail about her role in particular. But as far as the field epi goes, that's the next step in how we work the cases. And then we encourage the interviews to be done in clinic at the time of the treatment. So we'll meet with the patient, we'll offer the interview. And the reason why we think that this is better is because the faster that you get to the patient, the more likely you are to create rapport with them and for the patient to be open in order for them to provide more information about their partners and whatnot. And so we also encourage patients when we're talking to them to also bring their partners at the next appointment, if that's possible. Another thing that we do is we put a lot of importance on transportation, making sure that patients are able to get to the clinics. And if they cannot get back to the ordering provider, that we can refer them into an STD clinic. And this allows us an opportunity to get to know the patient better, to create a plan of care for them. So in case that they need to get tested in the future, they have a plan of care. Also, another thing that we're doing is in Massachusetts, we have a Bicillin distribution program. And so what this program does is we have Bicillin stored within our department. And whenever there's a provider, usually we see this mainly with private practices, private providers who might not have Bicillin in stock, and we can actually deliver it. So a provider will call us, or if we find out about a case and that might not have it in stock, we'll actually go and deliver it. We can deliver it somewhere between half hour to 2 hours, or we can deliver it at the time of the scheduled treatment. Also, for patients who might not have health insurance and their insurance might not cover treatment, this is a great way also to provide treatment for those patients. Okay. Next slide. So I want to talk a little bit more about our public health nurse, Lila Coverstone. So in 2005, we observed that our department, we were getting infants born to women with positive syphilis serology during pregnancy, and we're not always receiving adequate follow-up, and then they were not given appropriate treatment based on CDC guidelines. And due to this identified gap in care, our department, Dr. Kathy Shu and our director, came into a conclusion that hiring a public health nurse to follow up on these pregnant females with positive syphilis tests would be a good idea in order to follow through with the cases and make sure that patients are getting proper care and adequate treatment before, during, and then follow up with the babies after. So the public health nurse is a resource for all the field staff and clinicians if questions or problems are incurred during the investigation process. So Lila follows up on congenital syphilis cases, but she also helps us GYS with more complex syphilis cases. You know, if we have any questions, she's always there. She's a great resource for all of us. So for routine cases, the nurse engages with prenatal care providers to support the treatment and follow-up testing of the pregnant case. And she works hand in hand with us. So the GYS and the nurse could be working together to better follow up on these cases. And so this follow-up includes her ensuring the timely treatment. She'll also review our cases while we're working it and making sure that, you know, we're covering all bases and there's not any gaps missed. Additionally, the public health nurse, she will ensure Bicillin, and then she'll ensure the third trimester screening as well with the provider. So additionally, the public health nurse will obtain information on planned delivery hospital and send an informational letter to the labor and delivery ward to prepare them for the required testing, monitoring, and reporting of possible congenital cases. And so in this letter, she will also include her, phone number, so then the providers can call her at the time of delivery. And if she's not available, then this call will go to our medical provider, Dr. Shu. So how do we follow up on congenital cases? So all infants reported to Massachusetts Department of Public Health are reviewed and followed up by the nurse. Many of these cases are expected known prior because we're following up with a case. And so it will get thorough follow-up, maternal follow-up. For cases that are not known to the nurse prior to delivery, priority follow-up is initiated as soon as possible after the report is received. And many times, because we have very good reports with providers and they're aware of our public health nurse, they will reach out to her directly in reporting labs results for the infant. Also, as I said, the nurse will provide the letter to the hospital again with guidelines on testing and treatment for the mom and the baby. And then post-delivery, the public health nurse works with the delivery hospital and the pediatrician to ensure complete maternal and infant evaluation at the time of birth and monitoring testing of the infant by the pediatrician as needed. And usually then she'll do a 3 to 6 month check with the pediatrician to make sure that everything is okay with the baby. So in cases where we do have syphilitic stillbirths, the public health communicates with the delivery hospital and medical examiner office to obtain all necessary testing evaluation reports for complete documentation. And then the public health nurse is also responsible for the complete documentation of all required maternal and infant variables. Oh, sorry about that. Yeah, so, and then documentation of, so, okay, next slide. Okay, so how are DIS encouraging prenatal care and STD testing to pregnant women and OBGYNs? You know, we encourage STI screening at initial prenatal visit for all pregnant women. One of the most important things that we do is that we create really good rapport with providers. And, you know, those relationships take time to build, and just making sure that providers are, you know, talking to their patients and testing them often. Another thing that we're doing is we have partner services pamphlets for providers in waiting areas, whether that is at OBGYN or whether that is at an STD clinic. And then one of the other things that Lila and I have been doing is we're thinking about doing presentations within like OBGYN units to kind of do like a syphilis 101 and what it looks like for women in prenatal care and what their testing should look like and follow-up should look like. We're also creating report with patients, you know, whether it is a patient, a female patient, or whether it is a man who's having sex with women, that we're making sure that we're educating those people and letting them know about, you know, what treatment and testing could look like for their partners as well. Patient education through the interviewing process, addressing a patient's needs to get tested. So pretty much just communicating with patients and educating them as much as possible. Okay, so local partnerships that we're engaging with. So because our field depots are located in different regions of the state, we have created different partnerships with different providers in different areas of the state. And those partnerships are very important. They take a long time for us to build, and staying in communication, providing information back and forth. Like one of the things that we do is providers will call us requesting data or history for treatment or labs on a patient, and we have a line in which it goes to our field operations managers, and that line is solely for record searches. And so that allows us an opportunity to not only detect some of the cases faster before they come in, but also to create rapport with providers and, you know, give us an opportunity to communicate with them. We also have the ability to offer direct, as I said, support for clinical issues around uncertainty of congenital syphilis and other STDs. And provider calls come in, and usually if it's around congenital syphilis, then Lila will take those calls and have more thorough conversations with the providers. Also, we have initiated technical assistance protocols when providers use treatment that are not standard or do not offer treatment to contacts or patients as recommended in the guidelines. And so Lila will assess the situation and offer guidance and kind of use her authority as a public health nurse with 20 years of experience to have conversations with providers to kind of put them on track and let them know what the appropriate route of care would look like. And so again, these partnerships require a lot of time. They require a lot of conversations, and it's not always easy, but you know, it's a work in progress, and we're doing the best that we can. All right, so what are some of the challenges? I mean, definitely some of the challenges are lack of prenatal care, and these are opportunities for intervention. And I think that for the 3 cases that we had with stillbirth, it was clear that late entry into prenatal care was the main concern. And I think this is a systematical issue that, you know, we all need to address as a society. But some of those factors could be homelessness, you know, opioid use. We're having opioid crisis here in Massachusetts, health disparities, undocumented statuses, no communication, like patients sometimes will not even have a cell phone, so it's very hard to get in touch with them, language barriers, transportation, mental health issues, domestic violence, and insurance issues as well, and patients not being able to get proper treatment. All right, so I had a conversation with Dr. Shu the other night, and she told me to make this the last slide. She said, you need to tell them the secret sauce ingredients of Massachusetts. And so the first secret sauce is having ELR, electronic laboratory reporting access, just making sure that we are sorting all the cases that are coming through with a positive syphilis serology. It's definitely a plus. 100% assertion of women in childbearing ages. I mean, we probably had around we had about 150, maybe to 200 cases that we followed up with in those women of childbearing ages with positive test results of ages 14 to 49. Making sure that we're following up on their pregnancy testing, super important. Also, exchanging of information with providers, ability to provide historical data such as past labs and treatment, it's definitely a plus. As I said, that's where the report starts with providers. So another one is clinician to clinician relationships. Our public health nurse has 20 years or plus experience in clinical care, and it's important that, those conversations are happening, whether it is in the OBGYN units or whether it is within community health centers and private providers. And so another thing that we're doing to build these clinician relationships is we have the Sylvia Rattel PTC Training Center ran by Dr. Kathy Shu. We're creating trainings for local providers to inform them and keep them aware of recent trends and updates on congenital syphilis cases. And she has direct access to providers, which is awesome. And last but not least, of course, PhilDep is creating better relationship with the community health centers and private providers. These are ongoing relationships and conversations. We definitely prioritize all pregnant untreated STI cases. It's our main priority. Quick response to the cases and intervention for all of these patients. And also, I would say that the Biosilin distribution program is definitely a plus, and it helps us very much with getting an in with the providers. And also, like when we go to an interview with a patient, we're like, well, I'm the person that, brought you the treatment, so let's have a chat. And it opens up means of communication with patients. So that's my presentation. Thank you very much, and I'm open to the questions.
Awesome. Thank you so much, Lorena. Before we jump into Q&A with Brandi and Lorena, I'd like to be sure you all are aware of the DIS Slack workspace that NCSD has. Slack is the communication platform of NCSD's community of practice for DIS, where you can chat with DIS from around the country and share resources on any topic from field safety to technology and partner services. We've also created a coronavirus channel, so you can easily find and share resources related to COVID right now. If you'd like to join Slack, you can use the link that is in the slide deck. Tiffany will also post it in the chat box. And in the chat box, there'll also be a link to our COVID Command Center. The NCSD communications team has been working hard at updating this part of our website with helpful resources for DIS and STD programs for clinics as well. So I encourage you to check that out. NCSD hosts weekly COVID information sharing calls for DIS every Tuesday from 3:15 to 4:15 p.m. Eastern. If you'd like to get added to that email list for those calls, please email me. So I just wanted to make sure to put a plug in for all of the great NCSD resources that are super relevant at this time. Before we jump into the questions, Lorena and Brandi, do you all have 10 more minutes to spare? I understand you have to hop on to other calls or other meetings, but I want to make sure we have time for questions.
Yes, I'm totally have time, sure.
Okay, what about you, Brandi?
I have time as well.
Okay, I'll definitely have a hard stop at 3:10, just to be respectful of everyone's time, but I want to make sure that we do get some questions answered. So let's see. Y'all have been quite chatty in the chat box. This is really great. I'm glad you found all of this very informative. One moment. So the first question comes from Robert. Robert asks, what factors do you think contribute to the increase in congenital syphilis? Is it related to clients entering care late or not at all, et cetera? Can you both answer that from your different perspectives?
All right, this is Brandi. I'll go first. So our increase has been a mixture of things. So as I mentioned, we have had an increase in syphilis. So, of course, you would have an increase in congenital syphilis as well. And then we are doing better follow-up and better reporting from our providers as well. That could also contribute to the increase. But, I think the main thing is, because there's been an increase in syphilis, of course, like I say, your congenital syphilis is going to follow for us anyway.
Yes, I agree with Brandi. Definitely seeing an increase of syphilis in Massachusetts as well, and it's definitely a contributing factor. But as I mentioned in the slides, I do believe that there's other factors, like I mentioned, like the opioid epidemic and people coming in late, or we've had a situation with the domestic violence where the mom was unable to come in for prenatal care. And so it's a question that remains about, like, what can we do to address some of these bigger issues to help us address congenital syphilis? And, we have to start thinking about it more that way, because in Massachusetts, I think that we're doing everything that we can to kind of prevent some of these things from happening. And I feel like the cases that we did have, it's hard to kind of point a finger at, like, okay, like, what is it and what is it that needs to be addressed? One thing I want to mention really quickly, it's like we are working also on the third trimester testing. And that's something that, Dr. Shu and everyone in the department is also working with, just to kind of fill any gap that there might be with that. And, but, the question remains open.
Great. Thank you so much for that insight. And again, thanks everybody who's still able to hold on to the line until 3:10. Even if you have to hop on to another meeting or call, this call is being recorded, and the slides and recording will be shared. So we'll get some questions answered so you can at least hear those on the recording. Let's see. The next question, scrolling in the chat box. Aisha asks, what are the risk factors for pregnant women?
Okay, so this is Lorena. What are the risk factors for pregnant women? I think the risk factors is definitely not getting enough adequate testing, and then, making sure that the partners are getting tested. That's super important. Making sure that the partners are also getting preventative treatment, because then there's a risk of reinfection. Having conversation, creating rapport with the patient as far as like GYNS and patient relationship goes. And then, again, focusing on the patient and provider, making sure the provider is staying informed to, make sure that the patients are getting the correct testing and treatment. And also having a history of serials of STIs. Like if we know that a woman has had previous history of STDs, then we know that that patient is at higher risk. Drug use, definitely we need to look into that. And again, all the issues that I mentioned earlier, definitely any kind of barrier that there is increases the risk of a patient getting an STI. So we have to think of it more of that way as well. That's my answer for now.
Great. Thank you, Lorena. Did you want to add anything there, Brandi? Or would you agree with what was said?
Yes, I agree with what she said.
Okay.
Yes, same here.
Robert also asked, are the majority of the cases in 2018 probable, confirmed, or not a case? Can you speak to that?
So in Arkansas, all of those are probable cases for us.
Okay.
Ours, it says, I'm not sure to be honest, but it's 7 presumptive congenital cases, so I'm assuming they're probable.
Okay, great. Thank you.
I will get back to you on this.
Thank you. If a client meets the criteria for early latent diagnosis, would they still need 3 injections?
For us, no. If it's early, latent, we still go with the CDC recommendations of the one shot. Of course, if it's late, latent, or over the 1 year, we do the 3 shots.
Yes, same for us.
Okay, great. Thank you. Let's see. What is your process for women who fall in the reproductive age range, test positive for syphilis, and report no birth control methods? Are they referred and linked to family planning?
So in Massachusetts, we don't really do any of that kind of follow-up. That's a conversation I feel like that the patient could have with a provider. But if I do meet with a patient and the patient tells me that, no, I'm not on birth control, but they want to, then I will go out of my way and make sure to provide them with some sort of resource on that. But as far as our protocol goes, we don't have anything like written on that topic.
Okay, thank you.
Mm-hmm. Okay, and to add to that, from Arkansas, so our STD and family planning clinics are actually housed in like the same local health unit. So I do believe that our nurses do discuss birth control and family planning options with those clients, and then can kind of just refer them for family planning if they need to. So I think it's on like a case-by-case basis.
Okay, thank you. Tiffany is working on getting us a new chat box. We're very chatty today, which is awesome. So there's a lot of questions, and we're reaching the text limit for the chat box. So I'll give that a second. She's working on that. While she's doing that, I still have the other chat box live on my end, so I can see what was already placed there. So give me one moment as I scroll. Let's see. One second. Do you all have the congenital syphilis investigation pending workflow generated by EGA once pregnancy status is updated to yes?
Can you repeat that question again?
I'm not sure what that is.
Let me, I can copy and paste it into the chat box as well. 1 second. Do you all have the congenital syphilis investigation pending workflow generated by EGA once pregnancy status is updated to yes? Amanda, who initially asked the question, specified and said that it's made in specific.
Oh, okay.
Right. So that, yeah, yes. So for us, it would prompt. So it goes in Lila's queue, in our nurses queue. But also, besides doing that and entering that variable, we also make sure that we're either testing her or sending her an email to let her know about that pregnant case.
Gotcha. Okay.
Yeah,
Thank
and then
you.
to add to that, so for us, once, because we have PRISM as well, so once we mark those individuals as pregnant in PRISM, it opens up a separate maternal record so that we can keep track of our maternal records. And then, of course, if it is a congenital case or probable, we actually have a congenital syphilis module or record that opens up in PRISM as well.
Gotcha. Okay. Regarding transportation, does your staff have insurance coverage for that in case of an incident? I'll also
so we actually.
Sorry, I was saying I was copying and pasting the question.
Go ahead, Brandi.
As well.
Okay. Oh, okay. Yeah, so this is Brandi. So we actually just asked that question a few weeks ago about insurance coverage for our DIS. So we did find out that we are covered under our state agency policy for insurance coverage, but we do, of course, have some small caveats where they have to be, we try not to transport children, of course, because I know sometimes we do run into issues where we have mothers who have other children that need to get to appointments and so forth, so we can't transport children. And then also, if they are under the age of 18, we have to get parental permission for those individuals. But to answer your question, our agency insurance does cover our DIS who are on work hours for transporting patients.
Great. Thank you, Brandi. And in Massachusetts, we actually, as of I don't know how many years it's been, we actually do not transport patients in our cars anymore because we did have a little incident a couple of years ago. So what we're doing instead, the only thing we're doing with our cars is we're transporting the bicillin to providers that might need it and patients. So what we're doing is we created a partnership with a taxi cab company, and so we're providing patients with taxi cab vouchers to take them from their homes and bring them to the appointments as needed. And that's been working okay. It is an added extra step, but we know that, the field epi's cars and I don't know, is not being, we decided to go with a different approach altogether.
Gotcha. Okay, thank you. I'll take two more quick questions from the chat box from earlier. One question was really quick. Can you share a copy of the letter that is sent to the delivery hospital? I believe that was for Brandi. If I may be mistaken, though. The letter that you referred to.
Yeah, we have one. I would be happy to share that. I don't know. I have to see if we can actually share it, but I'm sure we'll be able to share it. And if we can, I'll be happy to provide that with you.
Okay, thank you. Last question is bicillin distribution covered under 340B? Do you have to track this?
So Lila tracks it. She has a whole system. And so I don't know the specific answer to that question, but I know that it's very closely monitored and tracked by the nurse, the public health nurse that we've hired.
And to add to that, so for Arkansas, so that is the reason why we cannot give our outside providers bicillin because of the whole 340B 340B process. But we do, in some of our counties where we don't have a close hospital, we do have public health service agreements with those private providers so that we can actually take the patient over to the private provider to give their bicillin shot, but we don't actually do the where we can give the patient or the provider or doctor the bicillin. We actually have them come over to the health department if they need to have if they need bicillin.
Okay. Thank you so much. A special thank you to both Brandi and Lorena for your time today and for even staying over a little bit to answer some questions. We had a lot more questions that came up in the chat box. What I may do is just get those questions, compile them, and maybe send them to you, Brandi and Lorena, and maybe you can quickly send me back, email me some answers, and I can create a document of some sort to answer the questions that can go out with the recording and the slides, if you all are okay with that. Just because I want to make sure that people get their questions answered. Again, thank you all for joining today. Please complete the evaluation after the webinar has ended. In order to inform future webinars, you'll be automatically redirected there, but it was probably also put in the chat box as well by Tiffany. The recording of this webinar and the slides will be emailed to all of you who registered, and it will be posted on the NCSB website. If you have additional questions for the speakers or for me at NCSB, our contact information is right here in front of you on the slide, and it'll be included in the deck that you'll be sent. So with that, thanks again, everyone, and have a wonderful day. Bye.
Thank you. Thank you, everyone. Bye.